Hello, and welcome to the quarterly webinar of Parkinson's disease brought to you by Cure Parkinson's, the Journal of Parkinson's Disease, and the University of Edinburgh. My name is Tilo Kunath from the Centre for Regenerative Medicine, and I'm dialing in from Edinburgh, Scotland. Today, we have a very special webinar topic that's close to my heart, stem cells. So during this webinar, we'll hear from Rachel Gibson, a person with Parkinson's and a patient research advocate. Cheney Drew from Cardiff University, working on the patient experience in clinical trials for Parkinson's with a focus on surgical trials. And from the University of Copenhagen, Agnete Kirkeby, a world expert in the application of stem cell research for Parkinson's, and she's currently leading the clinical trial STEM-PD that we're sure to hear lots about. So first, we're going to go through some brief introductions from each of the participants, and I'll let Rachel start.
Hi, my name's Rachel Gibson. I've had Parkinson's disease for 16 years. And during that time, I've had DBS surgery, deep brain stimulation surgery, about 7 years ago. I'm particularly interested in research of new Parkinson's drugs because I used to be, before I had children, I was a research nurse for chemotherapy and drugs. So there are a lot of new drugs out there for cancer patients, and I used to spend quite a lot of my job designing the trial, consenting the patient, and giving them the chemotherapy. And now I have Parkinson's. I'm quite keen for new drugs to come up to help slow, stop, and even reverse my disease. Thank you.
Thanks, Rachel. Thank you very much. Cheney, please.
Thank you. Hi, my name is Cheney Drew. I'm a senior research fellow working at the Centre for Trials Research at Cardiff University. And I spend my time designing, developing, managing clinical trials, specifically in neurodegenerative diseases, with a focus on trials that include advanced therapies, so cell and gene therapies for neurodegenerative disease. And as Tilo said, I've been recently undertaking some research into the participant experience of people with Parkinson's who go through these complex clinical trials and see if we can understand how to make them better for people with PD.
Fantastic. Thanks, Cheney. And finally, Agnete.
Yeah, good evening. My name is Agnete Kirkeby. I'm on this call from Sweden. I'm a stem cell scientist and associate professor at Lund University in Sweden, as well as University of Copenhagen in Denmark, just across the bridge. And I've been working for many years together with colleagues on using stem cells to generate dopamine neurons as a stem cell therapy for Parkinson's disease. And after many, many years of testing this cell therapy in animal models, we have now succeeded in getting authorization for clinical trial, and we have transplanted the first patients in Sweden with this cell therapy this year, in February of this year. So I'm very happy to be here tonight to accept any questions that you might have.
Fantastic. No, it's very exciting times. So let's start right at the basics, so get everyone on the same page. So Agnete, if I can ask you, if you could just describe what are stem cells, where do they come from, and why are so many people excited about using them to treat Parkinson's?
Yeah, so I think the first thing that I'd like to make clear is that stem cells can be many different things. So when you hear the term stem cells, that can mean many different things depending on what type of stem cell it is. So there are many different types of stem cells, and they certainly don't do the same thing. So stem cell therapy doesn't mean one thing. It means hundreds of different things, and every single stem cell therapy is specially designed and specially made for one single disease. So that's important to remember when you hear about stem cells in the media. So we do have stem cells in our bodies. We have stem cells in our blood. They make blood every single day. We have stem cells in our intestines. They make intestinal tissue every single day. These are very good stem cells in our adult bodies. They're very functional, and they're functional our entire life. But the brain doesn't really contain stem cells, tiny population, but they're not very functional. They can't really repair the brain. So when we talk about stem cell therapies for the brain, we have to go in and use other types of stem cells that we don't have in our adult bodies. And in the case of our research and many other researchers in the field, we use this special type of stem cell called the embryonic stem cell or the pluripotent stem cell, which comes from this very, very earliest time point in development, actually just after the egg has been fertilized by the sperm. And these stem cells you can get from IVF clinics, where egg and sperm, of course, is used every single day for fertilization. And here you get these very early fertilized eggs, and some of these, of course, are used for reproductive therapy, but many are discarded every single day. And these surplus fertilized eggs can then be used for research. And these fertilized eggs can give rise to really special stem cells. This is what we call the embryonic stem cells. And what's so special about them is that they come from this early state in development, meaning that they have the potential to generate every single organ in our body. So we have this very special stem cell that we can culture in the lab, and then we can actually generate every single cell of the body depending on how we treat the cells. And that's, of course, fantastic because that means that we can make also nerve cells that we can't normally make in our own brains. So that's why we're so excited about these embryonic or pluripotent stem cells, because they have the potential to generate new nerve cells. And that's why we can use them to make new cells that can potentially then be used to transplant back in and repair the brain. And they can also be used for other diseases like type 2 diabetes, for insulin-producing cells, or cardiomyocytes, for heart failure, or muscle cells, for muscular dystrophy, and many other diseases. So that's why there's this general very high interest in these pluripotent stem cells.
Fantastic. That was very clear. So in terms of Parkinson's, in the simplest terms possible, how would you describe a cell replacement therapy, and how has that led to STEM-PD, the current trial that you're running?
Yeah. So when we talk about a cell replacement therapy, so a cell replacement therapy is basically a specific type of stem cell therapy. And when we say cell replacement therapy, we mean that we actually go in and replace that particular type of cell that has been lost in the disease. And when we talk about Parkinson's disease, we're focusing here on the dopamine neurons, because we know that dopamine neurons are the ones that are responsible for the main part of the motoric symptoms of the disease. So when we say cell replacement therapy, what we do is we make new dopamine neurons in the lab from these stem cells, and then we transplant those into the brains of the patient. So we're literally replacing those dopamine neurons that are lost, because our own brains cannot make new dopamine neurons once they've been lost.
Great, fantastic. So finally, briefly, there's a lot to say about STEM-PD, but could you just describe the trial in brief terms, and how is it similar to or different from any ongoing trial?
Yes, so we started a trial this year in February called STEM-PD, and STEM-PD is the name of the cell therapy product, the cell replacement therapy. And STEM-PD consists now of stem cells that have been cultured in the lab, and we have treated them in a very specific way with a very specific combination of factors to generate dopamine neurons in the lab. We actually generate very young, immature dopamine neurons, and then we transplant those into the brains of Parkinson's disease, individuals with Parkinson's disease. This is a very new technology. This is the first trial in Europe with this type of technology, but there are 2 other trials ongoing in the world. There is one trial in Japan, in Kyoto, that started in 2018 and then took a while to complete all the transplants of the patients, and we still don't have data from that. It's going to come later this year with a similar type of product, but produced in a little bit different way. There's also always these tiny differences in the way that you produce the cells in the lab, but the concept is the same. You make dopamine neurons from stem cells and you transplant those into the brains of individuals with Parkinson's disease. And there is another trial in New York that just reported 1 year safety data from 12 patients with a similar type of product, showing that this treatment is safe. And from what I've heard, they will proceed into a phase 2. So these are the 3 trials that are ongoing at the moment, and we are running now the European version of this.
Right, very, very exciting. So I'm going to ask Cheney a question. I'm not sure how familiar you are about this STEM PD trial, but in general, how would you view the consent process for these types of trials? So these quite advanced trials, a gene therapy or cell therapy, as compared to a standard, say, drug trial. So how would you consider the consent process, and how would it differ?
Sure. So as anyone who's taken part in research will know, it's really important that when participants are approached to take part in research, that they are given the opportunity to ask all the questions that they need to, and they need to make what we call an informed decision. So they need to have all the information available to them about potential risks and benefits of that treatment or that therapy that's being investigated. Because it's also really important to say we do clinical trials because we don't know if that therapy is going to work in people. And this is the only way that we can be sure. So people need to be able to make an informed decision. They're given a lot of information, and then they make that choice on whatever factors are important to them. So it's really important for these cell and gene therapies that are coming through in development now and into clinical testing. They differ from traditional drug trials in that they're a kind of a one-stop option. Once you've had a cell or a gene therapy put into your brain, you can't have it taken out. And so this may preclude them from taking part in other trials in future, potentially benefiting from other therapies. So there's potentially a lot more to gain, but there's also on the flip side potentially a lot more to lose. And it's really important that we make sure that our participants truly understand what it is that they're signing up to.
Great. So what, actually, can I ask Rachel a quick question? What are your thoughts so far on cell replacement therapy after hearing how Agnete has been describing it?
I think she's right. New trials, we've got to give it a go, because we're never going to learn anything if we don't, and things aren't going to progress. But some trials obviously are easier to recruit, I think, than others. And my particular interest in this sort of trial is that you have to have, or ideally you would have 2 arms: the placebo arm, which is a sort of arm that you get the same procedures, but you don't get the active drug, and then the active drug arm. And obviously, if that's a tablet taking, it's very easy, and you wouldn't really have too much discomfort from that. Too many questions, I shouldn't think. But obviously, if we're looking at stem cells and injecting them into the brain, the placebo arm could have the same procedure and just have salty water or something given in instead. And I guess as long as the consent is, the patient who consents is aware of that, then that's fine.
Is it fine? Is it fine? Would you sign up for a surgical trial where the placebo arm is salty water?
Well, I think that's really individual, isn't it? But I personally probably wouldn't. But then if nobody does, then we'll never know if it works. So it's a really important consenting process, I think, a drug like this.
Thank you. I'm going to ask comments from both Agnete and Cheney on that. So Agnete, what does the placebo arm look like moving forward? I think STEM PD is open label, but what does it look like moving forward?
Yeah, I mean, it's a very interesting question you opened there, Rachel, and something we discuss almost at every single meeting we have, and there's no consensus in the field. So the classical clinical trial approach is, as you say, you would have a placebo double-blinded control. And this works very well when it's a pill you're testing, for instance. It's much more challenging in a trial like this, because ethically you would be subjecting half of the patients to a sham surgery, a rather long surgery. You put them in anesthesia, you would inject saline, but on top of that, you would also have to give them immunosuppression because that's part of the trial. We don't, I mean, personally, I don't think it's ethically a good solution to do it like that, because it is quite a lot to ask for patients and not giving them a treatment. We do believe there are other ways of solving this. Large control groups, for instance, longitudinal follow-up, a long roll into the trials, you know, the history of the progression for each patient, which gives you a good control group. And then you can use in secondary readouts such as PET, fluorodopa PET, which is not affected by placebo, to support your conclusions of the clinical data. It is a very difficult question, and there's no agreement. In Sweden, they're not happy to approve a sham surgery control. In the US, they very much like it. So it's also something that the different regulatory authorities don't agree on. But I do think it's something we have to discuss with them, because as we're getting more of these complex therapies, gene therapies, cell therapies, where a sham surgery control can be ethically contentious, I think we need to find alternatives to that.
Cheney, comments?
Yeah, so what Agnete said, to a large degree, it's very ethically contentious, the use of what we call sham control arms, where a surgical intervention is needed. So one of the problems is that where we talk about sham surgery, there are different, it's how far do you take that sham surgery? So if you're going to be a true control for your transplant, as Agnete said, you'd want to do all of the things the same, including putting the needle into the same target area and injecting a very similar fluid into that area, but not including the cells. However, most of the sham controlled trials that are going on at the moment, mostly for gene therapy, and as Agnete said, in the US, the sham surgery stops at the level of drilling burr holes into the skull. So that's where you make an opening in the skull in order to introduce your needle into the brain, essentially. So at the moment, most burr holes, most sham surgeries only drill partial thickness burr holes, so they don't go all the way through the skull. But is that really a true control for your intervention? There are also other methodological ways in trial design that we can. So the point of a sham control is to reduce the amount of what we call bias in your outcome measurements. So how we test whether that therapy is working. So if people don't know and the people administering the treatment don't know, you reduce this bias if they don't know if they're receiving the therapy or not. As Agnete pointed out, you can do that with using other methodologies. So STEM-PD uses a trial within a cohort design, rather than what we call a two-arm parallel design that most people are used to. So you've got two very equal groups. You can use biased randomization, so more people get the treatment than placebo, and various ways. So it is very ethically contentious, and there is a lot of discussion in the field, both in PD and other neurodegenerative diseases and advanced therapies, about how we manage this issue.
Yeah, it's very complicated. So comments are coming in about this. Maybe Agnete can address one of them. Someone, Louise, has said, can we use match controls like they do in the exercise groups?
Yeah, I guess you mean, so you have a control basically for each patient that's very similar. And I mean, definitely that would be the aim, that you try to standardize your control group and your treated group as much as possible. I think there are many different possibilities. The big thing is we need to get the regulatory authorities to agree to one of these, because of course the placebo-controlled double-blinded trial has for so many years been the standard. So it takes time to get them to to convince them that new types of designs maybe is the way to go for these very complex therapies. I think it's interesting. Louisa also writes, as a person with Parkinson's, I would never let you cut my brain open with a placebo. I think, that's a very important thing to say, right? We need to listen to the patients here. And if the patients really think that this is completely out of the question, of course we can't do this. I mean, we have to take that into consideration and also tell the regulatory authorities about this.
Yeah, I think you said it spot on there, Agnete. I'm going to come back to the STEM PD trial because some of the questions are coming in about exclusion or exclusion. So someone has written that a potential exclusion is tremor dominant, and then someone else has written in, do I have a PINK1 mutation? Am I eligible? So what are the inclusion exclusion criteria for STEM PD at the moment as it stands?
Yeah, so the inclusion criteria is that you have had to have Parkinson's disease. You have to be diagnosed with Parkinson's disease, of course, and you have had you have to be 10 years into your disease, but still at a moderate stage. So a Hoehn-Yahr stage 2 to 3 in the off state. The age criteria is between 50 and 75. And then an important criteria is also that the individuals have to be responsive to dopaminergic treatment, because if not, we expect that they wouldn't respond to the stem cell therapy either. So these are the main inclusion criteria. There's lots of different exclusion criteria, such as overt dementia symptoms or contraindications to neurosurgery or severe dyskinesias. And of course, this doesn't necessarily mean that a larger patient group couldn't be eligible for stem cell therapy later on in the process, but you always have to choose pretty strict criteria for your first trial to make sure that your patient population is relatively homogeneous, because these trials are small in the beginning. We are only transplanting 8 patients here. So it would be too much of a confounding effect if the patient population was very variable. So this is simply the reason why. We also exclude tremor dominant disease. I could see there was a question about this in the Q&A. One person asks, does this mean that people with Parkinson's disease who are tremor dominant won't be able to benefit from stem cell replacement therapy? And again, that doesn't mean that in the long run. The reason we've excluded tremor dominant type of PD here is because in some cases, tremor dominant disease can be caused by a slightly different pathophysiology. It's not always as responsive to dopamine treatment, as is to the same degree as the rigidity, for instance, or bradykinesia. So this is the reason we have chosen to exclude the very tremor dominant disease. But in the long run, this could be included in later stage trials.
Yeah, I think it's important to say that the criteria, as I heard at a conference, usually expands quite a bit after the first trials. So DBS, there's a couple of questions about DBS. Is that an exclusion criteria?
Yes, that is an exclusion criteria. Yeah.
And then a question I was going to ask you anyways, but someone has also asked it. So if the current STEM PD trial is successful, how far away do you think this treatment could be available for UK or Sweden sufferers through the healthcare system?
Again,
probably get that question a lot. So.
Yeah, and it is a very relevant question, a very good question. The thing is, these trials are quite long because we have to wait for the stem cells we transplant them, and then we have to wait for them to mature. The nerve cells, they start communicating with the patient's own brain cells, and this takes a while and can actually, we know from experience, can take up to 3 years before the stem cells are completely mature. I mean, think about it, a newborn baby, it also takes a while for the brain of a newborn baby to mature. And that actually can take, up to 20 years before our brains are fully mature. And it's almost the same process that the stem cells are going through when we put them into the brain. They have to go through this maturation process that they go through when we're born. That's why it takes a while. So actually, the efficacy readout of the trial is 3 years. And since it's a requirement that you have 3 phases of clinical trials. You have phase 1, where you test the safety, and that's what we're doing right now. Then you have phase 2, which is a little bit larger trial. You include more patients, and you look for signs of efficacy. And then you have phase 3 with a larger patient population where you want to establish for certain, is this efficacious and is this statistically significant, and how big is the treatment effect? And since each of these trials, the phase 2 and the phase 3, each need to take 3 years, and we're right now in the safety trial, which takes around 2 years, in total it will take around 8 years to complete all the trials. Yeah,
So
I'm sorry it takes so long, but that's the way it is. We have to go through that route.
Understand. I'm going to come back to DBS in a moment, but just to really answer one of the questions about PINK1 and PARK and maybe DJ1, for these autosomal recessive young onset Parkinson's, is some of the mutation in one of these genes, are they excluded or included, or do they not check for these genes?
Yeah, we neither exclude nor particularly include them. So you wouldn't be excluded if you have a genetic form of Parkinson's disease. We don't screen the PD patient. So actually, it is possible that we have individuals in the trial with a genetic form of Parkinson's, which we don't know of because it's not an inclusion or exclusion criteria. As long as you fit into the disease duration of 10 years and the age span of 50 to 75 years, then you can be included.
Okay, that's clear. So going back to DBS, so Rachel, I can't remember if you mentioned, but you've had DBS, and so that means at the moment you would be excluded from this trial. So when you had DBS, were you given a heads up that you might be likely excluded from future trials? And what are your thoughts on that?
Yes, I was. So DBS is, well, certainly when I had it 7 years ago, there's quite a lot of preparation that goes into it. Just to see if you're likely to respond. So you have to have similar tests to check that you're still dopamine. You still use dopamine. There's quite a lot of psychological testing, memory testing. So it's a 3-day procedure, or it was when I did it anyway. And so you really are given the opportunity to talk as well about anything else. Do you go for DBS, or is there anything else you could have? Certainly at the time I was talking about having DBS, it seemed to be the most sensible option for me. There weren't any forthcoming trials, and I was told that were anywhere near the sort of similar treatment response that I would get from DBS. So there was no real thing to have as an alternative. And I'd got to the point where life was pretty difficult with 3 kids. I had really bad dystonic pain, which was really my worst symptom. And so when I chose to have DBS, it wasn't a difficult decision for me. But I was aware that it would mean that I couldn't have any trial drugs. I could obviously you can have normal prescribed drugs along with your DBS, but you can't go on any clinical trials because it's seen as a bit of a complicated extension to the results, I think. So because they do change your program on your deep brain stimulation quite often. Well, some people have it more often than others, but yeah, to get the best out of it, you need to be reprogrammed every so often.
Thank you. Thanks, Rachel. That was quite informative. Cheney, what are your thoughts on this, on excluding people with DBS on clinical trials, and how could this be remedied in the future?
Yeah, I think we've already sort of touched on some of the reasons why DBS might be added as an exclusion criteria at this stage. So clinical trials, when a new therapy is going through clinical trials, they go through a number of stages. So it's from phase 1 to phase 4. So phase 1 is very much about understanding safety and tolerability of a new therapy. And you work through the stages, including more and more people. And as you include more people, you tend to generalize over the population more. So to begin with, and STEM-PD is an early phase trial, we make sure that the inclusion and exclusion criteria are relatively strict in order, as Agnete said, to get that homogeneous population, so that people we're confident that people are very, very similar it gives us the best chance of finding a positive signal from that therapy. So we get more evidence that a therapy works, we can start broadening out those exclusion criteria. So it may be in the future that people who have DBS may not be excluded. Although I will hold my hands up and say I am not a neurosurgeon. There may be added complications of removing a DBS in order to have a stem cell transplant. So those factors would need to be considered, but it may be possible in the future. But at this stage, at this time, we need to give the therapy the best chance of having a positive signal. And that's why we have these tight exclusion criteria. So it doesn't seem very fair now, and it isn't. But the idea is, the hope is that it does broaden out as we go along.
That's helpful. I'm going to ask Agnete to chip in on this, but also address a question that someone put. So might be getting a bit technical. I think someone asked, are you putting the cells into the substantia nigra? You can address that question. And just theoretically, would a DBS need to be removed to do a cell therapy, or the target site's different in the brain? Agnete.
Yeah, so for the first question, we are not putting the cells into the substantia nigra, which is the normal endogenous location of dopamine neurons. We are putting them into the putamen, which is the target site of the dopamine neurons. This is where the dopamine is released, and this is where the dopamine functions. And this is in particular where there is a lack of dopamine in the Parkinsonian brain. We're putting them into the putamen because it has been shown previously, not from stem cells, but from fetal tissue, which is kind of a pre-runner to the stem cell trials that we have now, where fetal dopamine nerve cells. So this is a tissue donation from aborted fetal tissue. And that tissue then has been transplanted into the brains of patients, in particular here in Lund, in Sweden, that has been done. And from those studies, we know that it can work to put the dopamine cells into the putamen. They don't need to be in their endogenous location of the substantia nigra. And the advantage of putting them into the putamen is that they're in the right place, because this is a little technical, but the substantia nigra is around 10 centimeters away from the putamen. So if we were to wait for the cells, I already told you it takes a while for the cells to mature and start communicating with the brain. But if we were to wait for them to actually grow nerve processes all the way up to the putamen, we extrapolate that this would take around 5 to 7 years in a human. It takes around 1 year to do it in a rat. We know that the cells can do it. It's just a very slow process. And I don't think anyone would want to wait 5 to 7 years for the treatment to work. So we think there's a much better chance that the cells will work, and we know they can work if we put them into the putamen, which is the site where the dopamine is actually lacking. Sorry, the other question?
It's about DBS. Could you imagine, theoretically, someone with DBS in the future also receiving a stem cell therapy?
Yeah, I mean, I don't think there's any technical hindrance to it. I mean, DBS is normally in the subthalamic nucleus, so it is a different site of the brain, and it should be technically possible to go into the putamen without interfering with the electrode in the subthalamic nucleus. So I think that is possible. But I think, as Cheney just mentioned, in a clinical trial setting, it would be a huge confounding factor for us to include DBS individuals. It would be very difficult for us to interpret the results from the stem cell therapy if we had DBS patients included in the trial. And this is the reason simply that DBS is an exclusion criteria currently. But that doesn't mean that these two therapies couldn't be combined once we've been able to assess the clinical effect of the stem cell therapy alone.
Good. That's what I hope you would say. That was the right answer. Because I think Cheney mentioned taking out the DBS and going in, but theoretically, you don't need to take any electrodes out.
You wouldn't need to. No. Yeah.
The two locations are completely different, the two anatomical locations. So a lot of questions have been piling up. Some of them are short. So I think a lot of them are for you, Agnete. So if I just fire through a few of them. First one I'm going to ask is, why are under 50s excluded?
Yeah, that's a good point. Yeah, we have actually discussed whether we should remove the younger limit. I mean, we do have an inclusion criteria of having the diagnosis for at least 10 years in advance. So we are including most of the young patient population. Of course, the extremely youngly diagnosed individuals, we wouldn't be able to include, and those would most likely be familial forms of the disease, some of which are atypical. But it's a good point, and that could be something we might, discuss in future trials.
Yeah, that's good. Yeah, I think definitely that will expand. What are the risks of the transplant surgery itself?
Yeah, so those are very similar to the risks of a DBS surgery. It's a very the surgery in itself is very similar to DBS. So it's a burr hole in the skull, and then it's the insertion of a needle, and in DBS you insert an electrode instead. So those are the well-known possible risks of a neurosurgery, such as infections or edema or bleeding in the brain. But I will say that the neurosurgeons are very good in general at avoiding that. They do a very meticulous planning. They scan the brain in advance of every single patient to make sure that they're avoiding big blood vessels, that they're avoiding penetrating crucial brain structures that they might damage on the way. So they actually meticulously design the neurosurgery individually for every single patient to make sure that they're not hitting or damaging any crucial regions of the brain.
Yeah, that's a very good answer. It's very controlled, functional surgery where a lot of things are under control. So there's a question that I think maybe I'll ask you, but you won't be able to answer, but maybe you can explain the trial a bit better. So someone's asked, any positive feedback from the trial that happened this year in February? So I know the person is referring to you transplanted one person this February, and the trial is of course a 2-year trial or something, but I don't know, can you say anything about how it went?
Yeah, so I mean, it's too early for us to release any data from the trial. We can just say that we've transplanted 4 patients so far. So far, there haven't been any safety concerns, but it's too early to say anything about functional efficacy because we have to wait for at least that 1 year. It's the 1-year endpoint is the time point where we can start releasing data from the trial, and we still haven't dosed all the patients. So in total, we will be dosing 8 individuals in the trial. So far, the trial is progressing as planned, and there hasn't come any major safety concerns up so far.
And a technical question about bilateral or unilateral. How are you doing both sides at the same time?
Yes, and this is actually a big advantage of the stem cells compared to the previous older trials that were done with donated fetal tissue, because in those trials there was never enough tissue. You were dependent on the amount of donation that you could get on every single surgery day, and there was never enough tissue to donated to transplant the cells bilaterally. That problem we don't have anymore because now we produce the cells in the lab, and we can produce, as many cells as we want. And then we freeze them down in little vials. And right now they're actually located in a freezer in London, at the Royal Free Hospital in London. And then we can ship them to the clinical sites. And then we just ship the amount of cells that's needed for each patient. And then we can go in and do everything in one surgery. And I think so that means the surgery is a little bit longer, but on the other hand, it also means that the patient only needs to undergo one surgical session, which we think is a big advantage.
Okay, I'm going to switch to Cheney. Can you maybe give some ideas about how patient participation involvement could influence such a trial, such as STEM-PD or other trials, patient voice? How could they design or help make these trials much better?
Yes, absolutely. So I think most people, particularly in the UK now, are quite used to sort of the concept of public and patient involvement in research, and being asked to get involved with the planning and design of clinical research. Now, we would argue that that the public and patients and people with lived experience can be included at all stages of the research life cycle. So that really starts from developing the research questions. You know, what is important to you? What needs to be answered? And I think in this case for stem cell therapy, the patient voice is really important in how we design the trials to be as sort of patient friendly and as acceptable as possible. So some of the work that we've done in the past has shown that to make the experience easier for patients, nothing's groundbreaking, but it's small little changes in how you run and manage the trial make a big difference. You know, the people that volunteer for these trials give an awful lot of themselves. They're extremely courageous in volunteering to go for these very novel therapies. So it's really important to involve them in designing those trials so that we can make it as acceptable as possible, making the information that we send out to people as readable and as useful as it can be, so that everyone knows what's going on. It's about what we measure, it's about how we measure it. Patients can feed into all of that. Patient representatives are also really, really important for helping interpret translating the results of trials back out into the community and being a conduit for channeling those results back out to the community and making sure that they are fed back out in a really understandable way. So they can be involved at all points, I would say.
Yeah, good, fantastic. Rachel, do you have a comment on that? I think you've been asked for your opinion on some trials in the past.
Yes, I've helped some pharmaceutical companies in the past before I had Parkinson's. So I think patients should be involved, or at least, patients should be involved. Certainly looking at things like, for doctors, I think the number of blood tests probably isn't that interesting. You know, if they have them 1 weekly, 2 weekly, 3 weekly, I don't think it matters to some people who are writing research documents or trial documents. But I think for a patient to have to trek weekly to a hospital or even to their GPs to have a blood test, it takes quite a lot of energy out from them. It ruins their day. It could be in the middle of the day. So I think it's really important to, like Cheney was saying, the little things. It's actually quite important to look at those and how much it interferes with their daily life, especially if they're on, you know, if there was a placebo arm. I know they shouldn't know it is, but obviously you're expecting people, whether they're ill or not really, to take time out for all these extra tests that you have. So it's quite important to make sure that they're all really necessary, I think. I think COVID actually helped that. Talking to my consultant a bit about trials, he said that while COVID was on, they were able to keep an eye on patients, but they were doing it a lot from video calls and going locally for their blood tests. And actually they've kept that going because there's not always a physical reason, essential reason for them to come in to have their blood test taken in the hospital. They could easily have it done at GPs. And so I think there's maybe some benefits came out of COVID.
Yeah, thank you very much. So it's still lots of questions coming in. I'm not sure we can get through them all, but here's I think one for Agnete. Would a patient have to stop dopamine replacement therapy, I think meaning drugs, after having stem cell therapy?
Yeah, a very good question. And no, we don't take away the dopamine medication from the patients, of course, because we know that it takes a while until the stem cells will start working. So what we do is we let all included participants stay on the medication that they're on, and then they're evaluated quite frequently by their neurologist to see if they need to adjust their medication. And normally the individuals themselves are very good at saying, you know, if they think the dose is too high or too low. And then the neurologist will adjust the medication as needed to handle the symptoms the best possible way. And this is actually one of the readouts of the trial. We look at what's called L-DOPA equivalence. So we look at how much dopamine medication is each individual on in the beginning of the trial versus the end of the trial. And if we see a decrease in the dopamine medication, this is also a positive readout of the trial. And of course, we hope for a decrease in those patients where the stem cell therapy is working.
Thank you. That's very clear. So here's an interesting question. I believe an exercise regime is being mandated for the participants in the Kyoto trial. Is this going to happen for the Lund Cambridge trial?
Oh, that's a very interesting question. We're not mandating that, but it's probably a good idea because quite a lot of research in animal models has actually shown that you can improve the effect of the graft if you stimulate exercise in animals. And this is probably because of what we call graft training. So you basically stimulate the cells to work faster and to work better and to integrate faster into the brain that they've been put into. So actually, it's a good suggestion. We haven't included it now, but that could be something that we could consider for future trials.
Yeah, I think on a previous webinar, we covered exercise. Julie Jones was involved, and also Julie Jones' Edinburgh Parkinson's lecture was all about exercise. Exercise in general is very good for people with Parkinson's, with or without a stem cell therapy, I think. So there's an interesting question about how is it determined whether gene therapy or stem cell therapy is right for you? And for that matter, what is the difference between the two? So let's get this basic thing out of the way. What is the difference between a gene therapy and a cell therapy?
Do you want me to take that one?
Oh, yes. You or maybe, actually, all of you have been involved. So maybe I'll let you start, Agnete.
Yeah, so gene therapy is a therapy where you put, normally you would put a virus into the brain because what viruses can do is they can deliver genes to your cells in the brain. So that means you're not putting in a new cell, but you're kind of enhancing the function of the cells that are already there. And gene therapy is in general something that's mainly investigated for genetic diseases. So if you know you have a defect gene, like in cystic fibrosis or in Duchenne muscular dystrophy, then it makes sense to go in and correct that gene, put in a healthy gene, and then you've kind of solved the problem. It's a little bit more difficult in Parkinson's because we don't have, for most cases, it's not a genetic disease, right? Or we don't have a single gene that's mutated. But that said, there are groups that are working on gene therapy, and the approach here is to put in genes that can help other cells to produce dopamine. So you can kind of hijack cells that don't normally produce dopamine, you give them the enzymes to produce dopamine, and then they start secreting dopamine. The potential problem with that is that you can then overload the brain with dopamine and it's difficult to control. But there are some of these in clinical trials. There are also clinical trials with GDNF. Many of you have probably heard about that. And GDNF is a growth factor that can promote the outgrowth and potentially the survival of the remaining dopamine neurons in the brain. And there are trials ongoing with this, particularly in California. There have also been trials in Cambridge. And actually, this is still ongoing. There have been some failed trials, but they've really improved the delivery of the vector and the expression of the GDNF in the brain. So it'll be interesting to see how these trials pan out.
Thank you. Rachel, you've been involved in gene therapy trials, I think?
Hi, yes, I have, but I have to admit, it was a very long time ago. I was involved with the first Oxford Biomedica gene therapy trial. So it was with cancer patients, not Parkinson's patients, who had skin lesions. So obviously it was injected in, and it was a lot easier to monitor and a lot easier to evaluate. And this was just a phase 1 safety study. It was taken really seriously at the time, with the idea that these viruses could replicate. Obviously, they were known not to be able to replicate because they've been basically mashed up so much that there was going to be no replication. But for everybody's to make everybody feel better, we had lots of PPE on, and it was all very seriously contained. I'm not sure that's probably the case now, but it was very interesting at the time. It was a really new thing to do, and it was fascinating because we injected it into breast skin nodules and melanoma patients who at the end of their life really had no other treatment to go for. And one lady's breast lesions virtually vanished in the time that she was on the trial. So obviously something was happening. And I'm sure they've gone on now to do further research into it.
Yeah, I think the safety of the gene therapy trials are looking much, much better than they were a decade ago. Actually, I had a question that Simon answered for you, Cheney. I don't know what your thoughts on this are, but if one of the trials in, for example, Japan proves successful, and we get the results from that, would this speed up approval in the UK, or would the current trials in the UK need to be completed first before we get approval for UK, UK use?
It's a great question. It very much depends on the similarity of the product. So stem cell products that are being developed, they're all individual products. And so they all need to be individually tested for safety. It's very similar to when you're looking at sort of standard drug trials. So everyone might be, people might be familiar with things like citalopram as an antidepressant. There's an extremely similar molecule called escitalopram, which is essentially the same. It's just a very, very minor modification of the molecule. But because it's a different molecule, you do have to prove that it's safe and that it works in people before it can be licensed. So certainly, if the same product has been tested in another country, you can go through the phases in a different region or a different authority, as we talk about regulatory authorities, you can go through them quicker. As long as you have the clinical information relating to that product that you can submit to the regulatory authority in any given region, then you can accelerate the sort of approval for that therapy coming to market. But it does depend on the identity of that product that you're testing.
I'm going to also ask Agnete, because the cell lines I know are completely different in the two countries. So what are your thoughts on that question, Agnete?
Yeah, I mean, if it's two different products, it doesn't help you much because each product has to be tested individually. But let's say if we test STEM-PD in Japan, and maybe this person is asking about Japan because Japan has particular rules about approving stem cell therapies for market. They can actually approve a stem cell therapy to market even before it's gone through phase 3. So that's different from all other countries. And that does mean that you can get faster to market in Japan. You would still have to go through a phase 3 in UK or in Europe or in the US to get authorization in Europe and US. But it would probably help your case if you have patient data from Japan, or you have post-market data, so what we call phase 4 data from Japan to support your claims of efficacy. So it might increase your chances of getting market authorization, but unfortunately you still have to go through phase 3 here.
Great. We only have a few minutes left and we still have lots of questions. So Agnete, this is a very relevant one. As you're aware, there are many symptoms of PD. In your work so far, which symptoms will the STEM PD product impact and which symptoms will it not?
Yes. So it's important to say that these cells are dopamine cells. So they're expected to work primarily on dopamine responsive symptoms. So this is, of course, mainly the motor symptoms. Other non-dopaminergic responsive symptoms such as cognitive impairment, for instance, or let's say non-CNS related symptoms, bowel symptoms, for instance, we don't expect that this therapy will work on. There is a discussion as to whether something like depression does also involve the dopamine system. And I know Roger Barker, he's very adamant to the idea that actually a dopamine cell therapy could work against depression symptoms. We just don't know yet. This is something we just can't test in the animal models. So we really don't know. We'll have to see what the what the clinical trial data shows us.
Great. And then two other questions about safety. So someone's asked, can the cells be rejected? If the cell's growth goes out of control, how can the growth be controlled?
Yes, very good questions. And actually, this growth out of control growth is, of course, the main thing that regulatory authorities want you to show that you don't have, because if you don't control your stem cells well, there is a risk that they can grow and potentially generate a tumor in the brain. So this is actually one of the things we spent most time on in the preclinical tests, long-term studies in the animals to make sure that these cells don't form tumors. We've transplanted more than 3,000 rats, actually. We've never seen a tumor. So we're very confident in our case that they don't. But of course, we have to see the clinical data on this. But this is something we really test very, very rigorously before we go into clinical trial. And then the other question was
about rejection.
Rejection, yes. So we do, the individuals in the trial are treated with immunosuppressive treatment for 1 year, so 12 months into the trial. And this is to avoid rejection of the transplant because it is a non-immune matched transplant. But because the brain is partially immunoprivileged, so it's not a highly immunogenic site, we have reason to believe that we can then retract the immunosuppression after a year and that the brain will then have a tolerance to the graft. We've seen this in the fetal tissue transplants. So this is different from a heart transplant, for instance, where you need to take immunosuppression for the rest of your life.
Yeah, that's good news. Only partial, so not a lifetime of immunosuppression. So last question, sorry again for you, Agnete. This is someone's asking about, is the transplant susceptible to toxin, or I guess maybe environmental toxins, but also is it susceptible to getting Parkinson's disease, I guess?
Yes. And here again, we learn from those old fetal tissue transplantation trials, because we have brains where we have grafted cells that have been there for a long time. We actually have a brain where the grafted cells have been there for 24 years, so it's a very long time. And from these grafts, we do know that, yes, the pathology in the brain can transfer to the transplanted cells, but it's a very slow process. So on average, what we see happens is that around 0.5% of the transplanted cells per year will acquire pathology. This means that 10 years after transplantation, we expect that around 5% of the cells in the graft have acquired a Parkinsonian pathology. So it does happen, but it's slow. And we do believe that with the timeframes we're looking at here, that because it's so slow, that the graft can still be functional for the lifetime of the patient.
Great, fantastic. I think that's all the time we have for questions. I'm just gonna sum up what I learned. I learned a few new things. It was fantastic. So the first thing that Agnete told us is that the stem cells that we talking about in this seminar are pluripotent. So Agnete described that these are very primitive cells that can be turned into anything in the body, any type of cell. So Agnete and others are turning them into dopamine-producing cells to replace the dopamine neurons that are lost in Parkinson's using a physical transplantation. So they physically put new cells to replace the cells that are lost. And they put them into the putamen, not into the substantia nigra, but the putamen is the area where dopamine is needed. And one thing I learned is that the good news is that although DBS, people with DBS are excluded at the moment, but the theoretical possibility of having a stem cell transplantation also and having DBS simultaneously is not theoretically impossible. The sites of transplantation and the placing of the electrodes are completely different anatomical sites, the putamen versus the subthalamic nucleus. So it's great to hear that people like Cheney are really trying to measure or trying to gather the patient experience, getting the clinical trial designed to include the voice of people with Parkinson's as much as possible. And the inclusion exclusion criteria we heard are quite strict. So someone mentioned that they are 76. They meet all the criteria, but they're 76 right now. So on paper, they would be excluded, but he probably is a very fit person that would be perfect for this trial. So 50, is 50 too old to be the lower limit? Should this be reduced? The answer, I think, is clearly yes. These criteria need to expand, and they will expand. I think as we move forward, we'll see expansion of these criteria as we had from DBS. Someone asked about DBS earlier. The inclusion criteria was probably quite small, but then expanded quite a lot. And I really appreciate all of the comments from Rachel. So Rachel has been living with Parkinson's for about 8 years, has had DBS, has some participation and advising on clinical trials. I think her comments were absolutely splendid. So I thank you also very much for joining the meeting. And I think that's us. Thank you very much, and we'll see you at the next webinar in about 3 months' time. Thank you.